So good afternoon, everyone. On behalf of the New York chapter of the American College of Cardiology, I would like to welcome you to the 50th annual Arvilla Berger Lecture. So Arvilla Berger was the wife of Captain Leo Berger, a Long Island businessman. In 1974, Captain Berger endowed an annual Arvilla Berger Lecture in gratitude for the services of their cardiologist, Dr. Harold Bernstein. The mission of the lecture is to bring outstanding cardiovascular scientists to New York to share their knowledge and experience with colleagues. And with that, it is my great privilege and honor to introduce our speaker today, Dr. Malissa Wood. Dr. Wood completed her undergraduate and medical degrees at the University of Missouri, Kansas City, followed by training in internal medicine and cardiovascular medicine at Beth Israel Deaconess Medical Center, where she also served as chief medical resident. Dr. Wood joined the staff of Mass General Hospital in 2000, where she is currently the Associate Chief of Cardiology for Diversity and Health Equity. She holds the Cathy E. Minehan Chair of Cardiovascular Disease in Women and co-directs the Corrigan Women's Heart Health Program. The program has helped improve the cardiovascular health of thousands of women and their families through its clinical, educational, and research efforts. Dr. Wood has made significant research contributions related to gender differences in cardiovascular disease risk, symptoms, and preventive strategies. She has also been a trustee and secretary of the American College of Cardiology and recently completed her term as chair of the American College of Cardiology's Board of Governors. And on May 1st, she will be receiving the 2023 Wenger Award for Excellence in Medical Leadership. On a personal note, Dr. Wood, I would like to thank you for being such an inspirational, genuine, and inclusive leader, role model, and mentor. You have impacted ACC and your mentees across the country in so many ways, and we are so honored to host you as our 50th Berger Lecturer. Before we begin, just a reminder to please enter any questions in the chat feature, and we will have a Q&A session following the presentation. Thank you very much.
Thank you, Dr. Vidula, for that kind introduction, and I will try to go. Can you guys see my screen yet? You cannot, right? There you go. How about that? Is that working?
Yes, it's working.
Great, great. It is really an honor to be here. I wish I were to be with you today. I wish I were actually in New York. New York is, other than Massachusetts and Missouri, my third favorite state. And it is really an honor to be the 50th, Berger speaker and, to represent, I think, all that the Bergers stood for. I read a little bit about them when preparing my remarks, and just the fact that I know Captain Berger was born in Hungary, moved to the United States, penniless, really escaping atrocities in Eastern Europe, and built an incredible shipping business. And I love the fact that he and his wife honored their cardiologist, and that they named this award after his wife, who raised their family and was quite an exceptional person herself. And in the next 45, 50 minutes or so, I want to talk about a few things that I think are important to all of us, regardless of the type of practice that we have or the role that we play in the practice. And that's really a sex and gender approach to cardiovascular care, and really trying to look at some global data and then bringing that into our local world, and then also talking a bit about expanding diversity and health equity efforts in the cardiovascular space, because I feel like we still have a lot to do. And I would also like to congratulate Dr. Vidula, who will be she's currently the chair-elect for the ACC Board of Governors, and really to congratulate her on her exceptional leadership, and to really thank you again for this incredible invitation. I have no disclosures pertinent to this presentation. And so I would like to kind of review some of the gaps in care, education, and research that have directly and indirectly affected cardiac outcomes in women, talk about some innovations that we are creating that may improve overall outcomes, and to recognize unique risk factors for a maternal cardiovascular risk that may portend long-term excessive cardiovascular risk, And then, really focusing on what we can all do to build and sustain a more diverse workforce in cardiovascular medicine. We started the cardiovascular program for women at Mass General in 2007. And the goal at that time was really trying to deliver care in areas where there were conditions that were poorly understood in women. But I really want to recognize the fact that by focusing a lens on one group that was a little bit different than another group, we were really able to begin to understand really the goal of health equity and diversity, which is understanding that we need to meet all of our patients where they are and to recognize the unique features that they bring to us. And I think that with the growth of these kinds of programs around the country, we have really raised the level of education. Now, many people ask me, do you think that we will always need programs that are distinct for women? And actually, my goal would be, and hope would be, that we would not, but that we would be able to educate all of our members of our CV team about these nuances. But I think as we understand, there are certain conditions that require sort of an additional level of expertise, and maybe having that sort of ability to manage these somewhat difficult cases will still be an area where a little bit of additional training and focus will be necessary. As I said, I want to talk first about the global paradigm of cardiovascular disease and the issues that we face, and then bring it a little bit more local, first to the US and then even to your state of New York. So in the world, cardiovascular disease is the leading cause of death for women. And we realize that that is about 35% of all of the deaths in women worldwide, and is the leading preventable cause of death. Now, whenever I talk about cardiovascular disease in women, the very bright person in the audience who's really aware of the literature and oncology will raise their hand and say, did you recognize that cancer is actually the leading cause of death in women up until age 80? And largely that's actually true. And after age 80, certainly cardiovascular disease takes off with the increased death from heart attack and stroke. But I will mention that, and it's important to recognize that the death rates in younger women, as I will show you, are increasing, and certainly the morbidity related to cardiovascular disease in women of all ages is rapidly increasing as well. And we know that some of these untoward outcomes that we've seen are really related to the fact that women remain understudied, underdiagnosed, and undertreated. And I would just, share with you sort of my snapshot of what led to my own passion in the area of cardiovascular disease in women. And that is that in the 80s, when I was training as a medical resident, we never really thought about myocardial infarction in young women. If a woman had chest pain, it was probably either a pulmonary embolus or maybe reflux. We didn't have highly sensitive tests to look for ischemia, but I can tell you that when a 50-year-old woman walked into the emergency room where I was doing my training at Beth Israel, and we quickly identified based on EKG findings that she was having an acute myocardial infarction, it was notable enough that the film crew that was there filming an episode of Nova and following some Harvard medical students actually quickly came to the emergency room and interviewed the patient and her family. Now, unfortunately, the woman probably was having a STEMI due to SCAD because she actually had a very profound complication and did not survive her cath. But I was so affected by that case, not only that, number one, it really showed us that this is something that can happen to young women, but more importantly, that there were cases everywhere that we really weren't recognizing. And so I really tried to get the best training I could, both as an invasive and non-invasive cardiologist, to really help answer some of these unanswered questions. I'd like to give a shout out to Dr. Roxana Moran and her colleagues. Dr. Moran led the Lancet Commission that looked at the global impact of cardiovascular disease in women and the state of the science in 2021, and really put out a goal that we would hopefully see significant improvements in cardiovascular mortality and morbidity globally by the year 2030. And this group really did collect abundant data and put it together in a really outstanding fashion. And I'd strongly encourage that you take a look at this report if you haven't had a chance to do so. And these were the aims: to promote cardiovascular health, improve outcomes, identify existing evidence and, more importantly, gaps in evidence, and really ignite globally interest in developing novel ways of caring for women throughout the world. Now, this global map, demonstrates cardiovascular death rates per 100,000 women. And I show this because I think it really paints a very stark picture and an obvious picture of where you live being really a key indicator of your overall cardiovascular death rate. And while we know women in North and South America largely have much more favorable cardiovascular health outcomes as compared to women in Northern Africa, Asia, and Eastern Europe, we recognize that even within the United States, there are significant differences, and I'll show you some data about that. But I think we really need to try to unpack these areas where we see such high death rates, and thinking about things like access to care, safety, the fact that many of women living in these countries don't even have basic human rights. And so I think working with organizations like the World Health Organization, we really need to do everything we can, taking what we've learned in the United States and sharing it globally so that others can benefit from all that we have done. This is a WHO map, and it's more of a heat map that really demonstrates those higher risk areas, and making it a little bit clearer of a message. And we can see that even in South America and Central America, the numbers aren't as optimistic as they looked on that map that I showed you earlier. And if you want to know what that little country was that was bright red on the earlier map, that was Turkmenistan. And this is a country where women do not have really equal rights. Women are living in a war-torn country with poor access to healthcare, and certainly recognizing that this is the country, based on WHO data, that women have the least good cardiovascular health and the highest risk of dying. And then if we look sort of at the next, if they're ranked number 1 and we go all the way to number 183, you're going to see that the United States doesn't stack up as well as we would have thought, looking at that map where everything was sort of light blue and dark blue. And in fact, if you look at the countries between the United States and France has the best overall cardiovascular health for women and the lowest overall death rate in women, you'll see that there are countries that have healthcare systems that are far less well developed than our own, and yet have better health for the women living in those countries. And so I think we really need to take a pause and think about, when we are in a country that is spending more per person on healthcare than any other country in the world, why are we not seeing equal or even better outcomes? And I think that really drives the question of what we can do to continue to optimize the care that we deliver to our patients. Now, this is looking from the CDC at some data that was updated in 2020, and really looking at death rates for adults. So this is not women only. And I just show this because I think it's so important to recognize that within the United States, there are such significant pockets of high cardiovascular disease burden, and of course, correspondingly higher death rates, really in the Southeast United States. But then even in specific states, you'll see counties, border counties in the north, and then certainly many of the counties in the Southeast. And then I think it's important to recognize that there are some counties where we just don't even have enough data to know what the overall rates are, but really seeing that these are very unfavorable. And then I was actually able to dig around and find a map of New York right here that demonstrates, as you can see, and although overall these are favorable compared to some of the other countries that I showed you, these are still, there's significant variability in heart disease death rate throughout your own state. And I think understanding this it's a complex issue. Now, this shows people living without health insurance. And I think that has something to do with overall risk, but as you can see, it's certainly not the whole story. And as we can see in Texas, it's really the state that has the largest percentage of underinsured or uninsured patients, largely due to the immigrant population, and Oklahoma as well. And you would expect that those states would have those higher rates, but in fact, they don't. So we really need to think about the fact that it's not only insurance, but also other variables. And then when we look around the world and we look at the types of heart disease that affect women, and this is data from the Lancet Commission, it's pretty clear that the overall leading cardiovascular health threat is still ischemic heart disease. And again, largely driven by the disease that affects women later in life, but we know again that ischemic heart disease is occurring at younger and younger ages. And hypertension as a driver of that ischemic heart disease is such a treatable condition, and yet we know that it's not being treated effectively even in our own country, and that by effectively treating hypertension, particularly in young patients, we could certainly reduce the majority of cardiovascular deaths in young patients. Now, one of the other things that we think may be driving some of the unfavorable data that we're seeing in the US is that while we were doing really well in the mid-2000s with educating women with campaigns like the Go Red campaign, where we actually got up to almost 65% of women to recognize their risk of cardiovascular disease, that recognition has actually dropped. And in fact, if we look at non-Hispanic women, Hispanic women, and non-Hispanic Blacks, the numbers and the recognition are even lower. And, I think that we need to really continue public awareness campaigns and partnerships with groups like Million Hearts, the CDC, and our county and state, health commissions to raise awareness, because there's so much that we can do to educate young women, not only for their own health, but the fact that they are in fact the glue of the family in most cases, and buy the groceries, prepare the food, and really set the tone for the overall health of the family. And so we really need to redouble our impact on education. Another area that was raised in our area of gap, our gap that was raised in the Lancet Commission really is the area of ongoing research. And despite legislation being passed in the 80s and 90s that really mandated inclusion of women in clinical trials, we still have yet to meet the mark. And in fact, looking at trials that we use to base our guidelines on, fewer than only 39% of the participants were women at most in these clinical trials. And if we break it down for some of the device trials, we can see that women were actually less than 30% of the population, while these are the trials that are guiding our care. And so I think it is very important that prospectively we try to understand, when we are designing research, what is it that we need to do as trialists to make trials really compelling for patients to want to participate, and how can we do a better job of bringing our trials to our patients who have jobs and have families, so that being in a trial actually isn't a burden, but it's actually something that patients will consider. And I really want to stress that this not only is an issue with regard to recruitment of women, and particularly young women, to clinical trials, but also to our Black and Hispanic and patients who've moved to the United States from other countries who may not have a level of trust of our healthcare system. And we really need to focus on that, development of clinical trials, and we need to work with our industry partners and continue to work with the NIH and NHLBI to really raise the bar on what is required, that what do we need to document that we are trying to recruit these populations, and how can we enhance keeping them in our studies. I am the Associate Chief for Diversity and Health Equity here, and we were shocked when we looked at our enrollment process and found that the majority of our trials do not have even a consent form available in Spanish. And when we look at the industry-supported trials, very few of them are available to patients who don't speak English, with the exception of some of the amyloid trials, because of sort of the increased prevalence in certain populations. We actually, have amyloid trial data and enrollment forms in Haitian Creole, but we don't have them in Spanish. And so I think we really need to do everything we can to make our clinical trials accessible to all of our patients, because we need that data to really continue to drive the care of our patients. And then, you know, to go back to where I was earlier, when I want to make the point that this absence of clinical trial or precise clinical trial data and this declining recognition of cardiovascular disease as a leading health threat and the undertreatment of hypertension, and obviously other things, certainly now like COVID, which this data here was published before 2020, but these are all variables that are pushing those heart disease prevalence rates and MI rates and mortality rates up in young women. So this is data from the World Health Organization that was actually published just at the end of 2019. And unfortunately, because of the pandemic, I think went largely unnoticed. And this is demonstrating that data from the US, New Zealand, Canada, the UK, Australia, and Denmark. So these are countries that have overall excellent health outcomes for the most part. And we are looking at this is actually data that's looking at cardiovascular disease death rate in women 35 to 74. So this is women who, you know, currently we know are experiencing an increase in their death rates. And we need to try to, again, really address this pretty quickly because those are not going in a favorable direction. And even countries like Denmark that have had outstanding outcomes, health outcomes in their system are seeing, you know, rapid increases in mortality. And so, you know, and I shudder to think what this looks like, you know, post-COVID. We have some data from the US, but certainly not going in a favorable direction. And then if we look at sort of, you know, comparing the US, which we saw was clearly not in the top 15 of countries for cardiovascular mortality in women, to France, which was the #1 best place to be a woman with regard to heart disease, we can see that even France has experienced an increase overall in acute coronary syndromes. So a 6% increase between 2004 and 2014. If you look closely at what were those forms of ACS, and this is not surprising, there was a decline in unstable angina cases and an increase in non-STEMI and STEMI cases. And I think that's really because we suddenly were using an assay that was very sensitive and more likely to pick up myocardial infarction in women, and certainly with our high sensitivity troponins, but overall increase even in France. And then if we look in the United States, we can see that in women under the age of 55, there was a 21% increase in hospital admissions with ACS, you know, between 1995 and 99, and 31% increase between 2010 and 2014. So whether that's related to recognition, whether that's related to other factors, we all know the data on, you know, that obesity, diabetes, hypertension, inactivity are all on the rise. But certainly these young women under age 55 who were largely protected from ACS in the past are in fact experiencing ACS at much higher rates. This is some data that I was part of pulling together, which is the sex differences cohort from the Young MI study. And for those of you who aren't familiar, Young MI looked at men and women under the age of 50 or below who presented to the Brigham and Women's Hospital or Mass General Hospital in Boston with an acute myocardial infarction in the 2000s, between like 2003 and 2018. And as one would expect, young women only made up about 20% of this population of young men and women. And there were some clear messages that we saw when we looked at the data and compared a young woman to a young man with a myocardial infarction. Women were much more likely to have underlying rheumatologic conditions like lupus and rheumatoid arthritis. Certainly, we know that in both conditions, cardiovascular disease and myocardial infarction specifically is the leading cause of death in those patients. The women were also more likely to be on Medicaid or to be completely uninsured. The women were less likely to undergo coronary angiography or revascularization, and they were less likely to be discharged on guideline-directed medical therapy. When we looked at the clinical presentation, and again, we had all the charts available so we could really pick out the data, we saw that women and men both experienced chest pain. Women were more likely, however, to comment or to complain as their chief complaint of something else, like back pain, neck pain, jaw pain, or fatigue. However, they had chest pain or they had chest discomfort. And I certainly think that it is important to remember, while women are more likely than men to have non-cardiac types of symptoms, if you take a good history, that chest symptom will usually be there in women with ACS. And the really hardest part of this data when we did this retrospective analysis was that the mortality rate was high in both groups, but women had a higher mortality compared to men at 11 years of follow-up. So I think, and those, remember again, these are young patients. And this data just also supports the fact that in general, from a number of other trials, women are less likely to receive GDMT for ACS. And we need to figure out what we can do to really implement more effective care pathways and to perhaps incorporate some AI elements and to enhance the elements that exist in our electronic records to try to identify gaps when they occur and to really force us to address why that gap is present. And it may be appropriate in some cases, but at least it makes us stop and think about why we aren't using guideline-directed medical therapy. Another reason that we are probably seeing some changes in the risk or the prevalence of cardiovascular disease in young women is that we're seeing more women presenting with pregnancy-related complications. But if we think about the overall lifespan of women, behaviors and other health conditions throughout the lifespan can really affect the cardiovascular health. And, if we focus on young women for a moment, data will support that it's important to ask about the age of menarche, because early menarche before 10 or late menarche after the age of 17 both suggest that there's probably some underlying issue, both either with the hypothalamic pituitary axis or the overall endocrine function that in fact places these women at higher risk of earlier onset cardiovascular disease. Certainly conditions like PCOS and premature menopause also up the ante, as I will show you, and increase that risk early on. And I can never talk about heart disease in women without reminding everyone of how important it is. If you're seeing a patient that is a young woman, take a reproductive history and ask her what kind of contraception she's using or isn't using, because young women who are still potentially taking some of the higher dose oral contraceptives and smoking have a significantly higher risk of thromboembolic events. And if a young woman has a cardiovascular condition and is not using contraception, it's important to educate her about her risk of developing complications of her underlying condition should she become pregnant, and emphasizing the importance of being followed by a cardio-obstetric specialist or someone who has expertise in understanding the impact of pregnancy on pre-existing cardiac disease. Pregnancy in and of itself, we know, is a stress test, and you fail the stress test when you develop preeclampsia, gestational hypertension. Premature delivery has some impact, not as much as a hypertensive disorder of pregnancy. And then certainly gestational diabetes has an impact both on cardiac outcomes as well as increased risk of developing diabetes. And then certainly peripartum cardiomyopathy has its own associated risks, conditions, and requires very acute and chronic management of the patients afterwards and appropriate clinical decision-making. And then women later in life have to decide. Certainly we know the data about HRT, but I'll show you some cases in which you may consider using short-term hormone replacement therapy if the patient really has substantial symptoms. So these are all things we have to think about when we see women with cardiovascular disease or cardiovascular symptoms. And, I think that when we recognize that heart disease risk goes up after menopause, regardless of the age, I think we need to recognize that overall a woman's body changes significantly when those estrogen levels fall. And those changes include cognitive function, higher risks of depression and anxiety, autoimmune disease risk goes up, obviously blood pressure goes up, the lipid panel changes in an unfavorable way, we lose bone density, and then we have all the other associated things like the urogenital symptoms, but in general, mortality in and of itself is associated with onset of menopause. And so certainly the earlier it is, we need to really think about each of those systems and how they're affected. This is some data from my colleague, Dr. Mike Honigberg, who has really done a fabulous job looking at data, both genetic genomic data, as well as large data from the UK Biobank to kind of draw a number of conclusions about some of these risk factors in women. And in particular, when Dr. Honigberg looked at the UK Biobank and the impact of premature menopause, so before age 40, on risk factors for heart disease, he saw that hypertension, hyperlipidemia, and type 2 diabetes were all significantly affected in women with premature menopause. And the mustard line is really women who had surgical menopause. The teal is natural menopause. And then the lighter blue is menopause at or after 40. And so you can see that the women with surgical menopause had the earlier onset of all of the risk factors, but that those lines really started to separate for hypertension early on. And unfortunately, with the UK Biobank, we don't have access to specific data about like, was the surgical menopause or surgery, was the hysterectomy with oophorectomy because of cancer, or was there another indication? But certainly in this series, that surgical menopause group does carry the higher risk of developing these risk factors that portend cardiovascular, that lead to cardiovascular disease. Then when he actually looked at the impact on the diagnosis of heart disease, he saw that for coronary disease, aortic stenosis, which I give him so much credit for thinking about that in this population, and even atrial fibrillation, those numbers were really different in those who went through natural or surgical menopause before age 40. And these are hazard ratios. And as you can see, with age at menopause, the younger the age at menopause, the higher that hazard, or the earlier these conditions occurred. And so I think it's really important to recognize that surgical risk, again, surgical here being the yellow, teal being the natural, the surgical numbers really stood out, but both were increased compared to women that had menopause at or after 40, which obviously you can see the hazard ratio markers here. So very important to think about. And just a couple slides, because I think this is important. Now you might say, I'm a cardiologist, what the heck do I need to know about hormone therapy, except that it's not good for people based on, the Women's Health Initiative. But I actually think everybody should at least understand if you treat individuals who use any type of exogenous hormone. And that can be men who are taking testosterone supplementation, women using estrogen replacement or hormone replacement therapy after menopause, and certainly individuals who are going, non-binary individuals who are receiving gender-affirming hormone therapy. We all have to be aware of some of the effect of these types of exogenous hormones on the cardiovascular system. Now, in our group, we do have a very talented young woman, incredible scientist and clinician, Dr. Emily Lau, who is actually very interested in this because her research is HFpEF and menopause. And she also has stood up a, menopause cardiovascular clinic to address some of these hormone-related questions. We know that the population in Women's Health Initiative was a focused population that received a very specific combination of estrogen and progesterone. So the questions of whether isolated, lower dose preparations would lead to the same increased risk of heart attack and stroke that was seen in the Women's Health Initiative remain unanswered. What we do know is that it's probably safe and reasonable to use menopausal hormone replacement therapy in women that are low risk. Now, we don't prescribe it, but we help the PCP or the gynecologist understand an individual patient's risk, because young women are having heart disease, as you've seen, and these patients will go through menopause and they will have symptoms. And so we need to kind of identify, like, what are the who should not get it? And largely anyone with any kind of significant cardiac disease should not. But there are some areas where we can recommend potentially considering it in some patients. And so the lowest risk group, and the group that we think for all women that it's probably reasonable to consider, and this is in the setting of needing hormone replacement therapy. So really intractable menopausal symptoms that are adversely affecting sleep, cognitive function, and quality of life. So very important things, like many patients are really affected by this. And so they would really like to be able to try hormone replacement therapy. So in young women that are under 60, who've had menopause and been in menopause less than 10 years, so that automatically means women who went through menopause after age 50. So none of those women who went through menopause early, and women that have a low risk of breast and cardiovascular disease. Probably reasonable to do some short-term hormone therapy. We want to avoid it in those at high risk of breast cancer or cardiovascular disease, in those who've been in menopause a long time, or in those who went through menopause early, and those who have some risk for heart disease or cardiovascular or breast cancer. You're also, if they have multiple factors, you're going to want to avoid it. And then there's this yellow area where there may be some ambiguity, but you certainly would want to ask about these other risk factors, such as thromboembolic disease, cardiac disease, liver disease, breast and vaginal cancer, and endometrial cancer. And so this figure is actually something that I always, tell our trainees, take a picture of it. It's really helpful to kind of help you think about green light, yellow light, and red light. And again, not really our place to write the prescription, but we need to help our colleagues understand when we're in that intermediate or high risk group. And largely patients who are in our practices as cardiologists are going to fall into the intermediate and high risk group. But again, a young woman who's in her mid 50s with palpitations, probably from her hormone related symptoms, who ends up in our clinic, this may come up. And so it's important for us to think about it. And then just to shift a little bit and think about sort of some of the other reasons we're seeing these increasing numbers in cardiovascular disease, and how we can potentially identify women and treat them aggressively to improve their risk and their overall health. And I think, again, thinking about women before pregnancy as an opportunity to identify these risks, because we know the things that increase our cardiovascular risk, such as insulin resistance, dyslipidemia, diabetes, and hypertension. Those are all factors that increase risk of preeclampsia. And we know that identifying those before pregnancy, getting on top of them, treating them, counseling the patient may improve not only the pregnancy outcome, but also down the road that risk for premature heart disease and stroke. And as I've mentioned earlier, these factors such as the hypertensive disorders of pregnancy dramatically up to 2 times increase premature cardiovascular events. And I think it's important to ask about this. I don't know how many of you do this in your practices, but again, when we treat women of all ages, we do ask about their prior pregnancy history and their fertility history, so that we have a snapshot of their overall health. And that really, some of those factors may have a strong impact on choices in the ways that we treat their overall cardiovascular conditions. And I just want to give show this to you to really give a plug to those who do work in the peripartum cardiomyopathy space, or the hypertensive disorders of pregnancy space, and the cardioobstetric field, because taking care of a pregnant woman is a complex process. Thinking about the vascular milieu of the placenta is really interesting, and it's an incredible opportunity for discovery. This is a very simplified model, but I think it's important to think about the placenta, the organ that is the placenta, because it's that unique environment that has mom's endothelium and blood cells, babies, and then the chimera of both. And that is where a lot of the issues arise, both in hypertensive disorders of pregnancy, as well as peripartum cardiomyopathy. So again, I appreciate all of the work done to really understand the placental unit better and how we can gain knowledge and understanding of the rest of a mom's blood vessels and cardiovascular system by more closely examining the behavior of the placenta during pregnancy. And again, some data from Dr. Honigberg, who once again, give him credit for thinking about this, looked at the impact of, or the effect that a hypertensive disorder of pregnancy diagnosis has on cardiovascular conditions, including coronary disease, heart failure, aortic stenosis, and even mitral regurgitation. So if we think about what are possibly underlying, common themes with these different forms of heart disease, I certainly think that potentially inflammation, but certainly fibrosis is common throughout these types of conditions. And this data is quite interesting. I want you to really focus on these red and blue lines here. So the blue is a woman who's been pregnant who did not have a hypertensive disorder of pregnancy complicating any of her pregnancies, and the red is a woman who did. And pay attention to those age ranges on the bottom. So it goes 40 to 70. So for coronary disease, and this is cumulative incidence, for coronary disease, the risk goes up really starting at age 55 pretty significantly in the women that had a hypertensive disorder of pregnancy. So there's not a big lag time there. And then after age 60 and 65, it goes up dramatically. Heart failure, a little bit. You can see those curves separating a little bit more. Also, age 50 really seems to be the time at when that heart failure really onset is increased in those women with hypertensive disorder of pregnancy. And I think this is absolutely surprising and really an area of ongoing investigation, which is the fact that the aortic stenosis rate in women that didn't have bicuspid aortic valves increases just staggeringly high with a hazard ratio of 2.9 at age 60, really increasing in those women with an HDP. And for mitral regurgitation, we saw a very similar, in fact, hazard ratio of 5 increase in individuals with a hypertensive disorder of pregnancy. So really thought-provoking. Certainly hypertension may be a driver of a lot of this, but it's not the whole story. We know that, this data from Timka et al., that managing hypertension after the onset of a hypertensive disorder of pregnancy in a patient can be really, we can manage it more aggressively by having the woman lose weight and have an optimal BMI. That seems to really help us manage hypertension, but it's very important to manage hypertension aggressively in all patients with a history of a hypertensive disorder of pregnancy, because we think that that early onset hypertension that we see when it isn't aggressively managed may be responsible for a lot of that excess risk that was identified. And as we think about sex and gender differences, I love this figure, which is also from the Lancet Commission, which really helps us think about the influence of sex and sex hormones. And remember, sex is the chromosomal assignment, the genetic assignment we were born with, and the way we present ourselves into the world is our gender. And there is a lot of overlap, but there are sex-specific risk factors. Then there are well-established risk factors that have some nuanced difference, but affect men and women largely similarly. And then there are the gender risk factors and influences, which are under-recognized. And I want to take this moment to also, I know we all have very short periods of time when we see our patients, but patients really trust and listen to their cardiovascular providers because the conversations we're having are very, very important. You only get one heart. If you're lucky, you get another one if you need one, but we need to take good care of our hearts. And so I think our patients really, really trust us. And so Remember that some of the things that people may not talk about, without you asking, include things like, underlying psychosocial stressors. We may see it if we look at social determinants of health. Not everybody has access to that data. Abuse and intimate partner violence, often something that is not reported when it's present. It's rarely present, thankfully, but may have a significant impact on cardiovascular health and overall health, obviously. And if you're not comfortable talking about this with patients where you think there may be a concern, then having appropriate resources to get these patients to the appropriate place to manage these concerns if they come up during a visit. We know that health literacy and social determinants of health have strong negative impact on our patients' cardiovascular outcomes. And I'll talk a little bit about that as I get more into the health equity discussion. I will really give a shout out to the authors of the 2019 lipid guidelines, because they did really point out the importance of these risk enhancers that allow us to sort of take the number that we get when we plug the data into the pooled cohort equations, and then either using a calcium score or these risk enhancers kind of often bump us up into the next risk category. And the ones that pertain certainly to women include the preeclampsia, premature menopause, the inflammatory diseases. These are things I've talked about, as well as South Asian ancestry for all patients. These are important things to recognize. And then when we think about, sort of a woman's across her lifespan, the different socioeconomic factors and how they can affect a woman's overall cardiac health and the cardiac conditions that affect women throughout their lifespan, we see that even in babies and perhaps even in fetuses with primordial prevention, there are going to be signals of an impact of the environment and the genes on the patient's cardiovascular risk. And, we used to think of loneliness and social isolation as really being something that only affected older women, but we now recognize that certainly this is something that we're seeing more and more in younger women and middle-aged women, particularly because of the pandemic. And then also remember, women will often put everyone else before themselves. So it's important to pay attention and consider psychosocial health in those considerations. Again, we are not trained, but we need to ask the questions and have resources to get our patients the care they need, recognizing that depression and anxiety, as I mentioned earlier, are more common in women than men. And data from this group demonstrated that men who've had a cardiac diagnosis, specifically coronary artery disease, regardless of their level of stress and anxiety and depression, will have similar outcomes. If we look at women after a diagnosis of coronary artery disease, those at the highest quartile of anxiety and stress have far greater events far earlier on than their colleagues who score at the lower quartile. And I know we're kind of short on time. There's a lot to talk about, but I just want to remind you all of some of the nuances with regard to the common forms of heart disease that we treat, namely ischemic heart disease. Remember, our women are more likely than men to have non-obstructive CAD, although overall, obstructive is more common in both. These non-obstructive forms may require more sophisticated testing, and we need to remember to keep our eyes open for things like MNOCA, SCAD, INOCA, and certainly in patients of all ages, we now recognize that the presentation with an ACS in women and men may be also related to both MNOCA, INOCA, SCAD, and even Takotsubo. So these are things we need to think about and look for. Some sex difference take-home messages in the heart failure space. Women are more likely to experience cardiogenic shock in the setting of a STEMI or acute MI than are men. Women they wait longer for VADs and have higher waitlist mortality. We know of the complications related to transplant, certainly, particularly in women who've had, children, but thinking about the impact that sex and gender can have on our patients with heart failure is critical. I won't go through this slide from Clyde Yancey, which was in JACC in 2022, but he did a beautiful job highlighting sex and gender gaps that exist in the heart failure space. With regard to arrhythmias, it's important to remember that, and again, I showed you the data on ICDs. Women made up fewer than 30% of the patients in the key ICD outcomes trials. And we know that in women, particularly women with non-ischemic cardiomyopathies, the likelihood of them getting an inappropriate shock is higher than it is in men. And the utility of having a device in place may be less beneficial, particularly in that group. And so we need ongoing data collection and trials to look at ICD indications in women and men. With regard to AFib, more common in men, but women are more likely to have a stroke when they have AFib, and they are still less likely to receive DOAC therapy. We know that Blacks and Hispanics also are less likely to receive DOAC therapy. So a lot of work to do there. With regard to maternal mortality, we all, I think, are aware of this. It is unacceptably high in the United States. Some of that data is driven by the fact that we actually started collecting data in a very, very careful way. But we know that the drivers of increased mortality are health equity drivers in many cases. And we know that the highest risk group for maternal mortality is Black, non-Hispanic women. There are many reasons we're seeing this increase. A later age of pregnancy, greater likelihood of having those risk factors that I showed you earlier, such as hypertension, obesity, diabetes, for cardiac heart failure presentation or ischemic heart disease during pregnancy. And certainly the hypertensive disorders of pregnancy are increasingly common. These are 4 key things you need to know when you're assessing women that are pregnant. The highest risk of death, again, as I said, is in Black women, who have 3 to 4 times higher risk of dying than white women. Age over 40, 30 times higher risk compared to young women. A history of hypertension increases risk of pregnancy-associated MI by 13-fold, and obesity is quite common. That's obesity prior to pregnancy. It was present in 60% of the women who succumbed to cardiovascular disease complicating pregnancy. So ask about pregnancy history, ask about ages at menopause, really important things. Leverage the EHR. The EHR controls all of our lives. Let it do something nice for us. Create algorithms to screen for pregnancy-related complications, to also do pre-pregnancy risk assessment. Dr. Afshan Hamid at UC Irvine has developed a really nice Epic tool that she shares free of charge. If you're interested, I'm happy to share more information about that with you. You do have to get your team at your site to implement it into your EHR, but you don't have to pay Epic anything to do that. So it's really important, and that allows your colleagues to screen for cardiovascular risk factors in women coming in for OB visits. Finally, let's think about equitable care for women, such as education, using technology, doing appropriate research, but let's think about ethical care for everyone when we address social determinants of health. Again, these are the things that we know are really important, but we don't measure them very well. Access to care, education, social supports, culture and language, physical environment, economic stability, sexual orientation, and the presence of systemic racism. We need a more diverse workforce to take better care of our diverse population of patients. As you can see, fewer than currently 5% of cardiologists are Hispanic, fewer than 3% are African American. We need to change these numbers. We need to mentor, we need to build the pipeline, we need to close the holes in the pipeline, and we need to recognize the data that shows that provider-patient concordance makes a difference, or at least building and creating a workforce where those providing care can provide the same kind of care as someone who is concordant to the patient we're caring for. And that's a really important aspect of education. We need to look throughout the way that we train, the way that we support careers. We need to look at the way we deliver care, and we need to assess within each of our own institutions and practices and look for the gaps in health equity, in pipeline development, in retention, in mentorship. These are all areas where a little effort goes such a long way. And not only will this help us with regard to the outcomes for women, but for all of our patients. And remember that if you are not part of the solution within your organization, you are part of the problem. And so I think that while these are not always easy things to do, like getting the social determinants of health incorporated into the EHR, or getting solutions to be able to address the individuals who screen out positive. But by doing something like that, we know in cardiology, there's abundant data that social determinants of health, when addressed, can reduce readmissions for heart failure, improve mortality after myocardial infarction. So these are things that are possible. We just need to do them. So take home points: cardiac disease, leading cause of death worldwide. Ischemic disease drives this, and that's largely because of the untreated hypertension globally that we see. We know in the United States, hypertension is still a huge issue, largely related to obesity, sedentary behavior, poor diet. These are things we can treat. We need to create solutions for equitable care to treat these. Reproductive history is very important. Psychological health is important. We need to consider screening for it in our practices, and then having resources that we can refer our patients to for these discussions. Sex and gender disparities exist, and disparities based on race and ethnicity exist. We need to put a lens on those disparities and address them. And we need to create a diverse workforce so that we can better address the needs of our patients. And with that, I will stop and take questions.
Thank you, Dr. Wood, for really an amazing talk. You have given us a lot to think about. We have a question from Michelle Rothenstein. So are there any collaborations or studies showing how OB to cardiologist referrals when a woman has a pregnancy complication can help reduce these heart disease pregnancy associated risks?
That's a really wonderful question. And I can tell you that the HOPE registry, which is based at Mid-America Heart, and Mass General was one of the sites, had a pilot project which just completed enrollment, and they looked at that specific question in pilot data, which were, patients in 2 systems who were referred by obstetricians to cardiologists, and they looked at their outcomes, and these are short-term outcomes, like, pregnancy outcomes and, 1-year outcomes, but they will use that data to not only they will publish it and inform us, but certainly we'll use that to hopefully get more funding to develop a larger network. They've already recruited sites, but really to implement the long-term study. We certainly have, anecdotal and small center data. There are small center reports of how cardio-obstetrics programs improve outcomes. But I think it's really important for us to look at this prospectively and recognize that there could be bias in some of the referral patterns. And so we need more data, but there is no data to show that there is any negative impact of doing this. And I think that's why strengthening the cardio OB network, and you may be aware that the ACC just developed a new section, and I'm so proud to have been part of the first work group that led to that section, and that is the reproductive health and cardio-obstetrics section. Everyone can join at no cost this year, and that is really going to be helping us develop networks within our own systems to be able to do the kinds of things that in this question to really manage that cross referral, right? So they refer to us, and then when we see patients that we follow for heart disease who want to become pregnant again, we refer them to MFN. So thank you for asking.
If anyone has any other questions, please enter them in the chat. But in the meantime, Melissa, can you talk a little bit about some of the resources available through ACC to help women who are taking care of these kind of patients, and also for just career counseling for women?
Sure. Women all throughout their careers can access mentorship. As I mentioned earlier, I had the great fortune of traveling to Rochester to actually do some mentoring of medical residents now quite a few years ago. But there are mentoring opportunities specifically for medical residents, both for women, for Black medical residents, Hispanic medical residents, and the LGBTQ groups that will allow mentoring early before you become a cardiologist to build our pipeline. At other stages of your career, there are also opportunities throughout the college through both leadership development and sections. And then there are even ways of finding mentors through the college tools that are available. The new format called Doc Matter is another way of connecting and developing mentorship. But I will say the thing that's worked best for most people is participating in college activities and meeting a mentor and, really developing along an ongoing mentor-mentee relationship that you've created based on shared interests. I think that more specific and very kind of boutique, if you will, way of finding the right person. And that's often done best through finding people outside of your organization because they may be a little bit less stuck in certain patterns. And so I would strongly encourage, participation. And then for cardio obstetrics, there are a number of available resources within the cardio obstetrics section link in the college, recorded presentations, and for anyone that hasn't signed up for it, the ACC Everywhere is amazing. If you signed up and attended ACC this year and paid, you will have access to it. And it includes all of the recorded programming of all ACC courses this past year. And there's a lot of cardio OB available. And it's basically like Netflix. You just type in what you want and you can watch it at your leisure. So a great way of also getting some additional credit if you need it. So lots of resources, and happy to help in any way I can if you need any guidance regarding cardio obstetrics resources.
Thank you again, Dr. Wood. It's really an honor on behalf of the New York chapter of the ACC to host you as our 50th Berger lecturer. And thank you everyone for attending this lecture. Have a great afternoon.
Thank you.